Hi guys, welcome to our presentation for Nursing 520, Research and Evidence-Based Practice. I'm Kirsten.
I'm Cynthia.
And we're going to be talking to you today about which infant feeding modality is best for mitigating symptoms of neonatal abstinence syndrome. I'm sure you're all aware of the fact that the United States is currently in the middle of an opioid epidemic. In 2017, the Department of Health and Human Services Secretary Eric Hargan declared the opioid use epidemic to be a nationwide public health crisis in a press release in October of that year. In April of that year, HHS had introduced a 5-point opioid strategy to address the addiction epidemic, with points for prescribers such as how to handle opioid and narcotic prescriptions for individuals with chronic pain issues, and also post-surgical pain management tactics. We also began to see the opioid epidemic rear its ugly head in the American healthcare system in all aspects and specialties, including obstetrics and pediatrics. We saw lots of babies that were born with neonatal abstinence syndrome, or NAS, which is a condition that occurs when an infant who is exposed to an addictive substance in utero experiences rapid cessation of exposure and suddenly begins to withdraw. So this happens when they're born and they're no longer getting that constant exposure from mom's blood supply. NAS is characterized by symptoms caused by disturbances to the following body systems: central nervous, vasomotor, respiratory, metabolic, and gastrointestinal. NAS is assessed by the Finnegan scoring system that we have posted here on the right, and it looks at the 21 most common symptoms of NAS. And this is assessed by nurses every 4 hours in the nursery. A little more history on NAS. The first clinically documented case of NAS in Western medicine was in Germany in 1875, and it came to the United States a little less than 20 years later in 1892. In 1999, the United States had an average incidence of NAS of 1.5 per 1,000 live births, so less than 1%. And in 2011, this number had jumped significantly to about 6.5 per 1,000 live births in the United States. Still less than 1%, but significantly more than years past. As you can see by this map provided by the CDC, we don't have information on all of the states' incidences of NAS, but we can see from the states that we do have data on that NAS is not equally distributed among the United States. In West Virginia, for example, the 2011 incidence was 32.1 per 1,000 live births, which is significantly higher than the national average for that same year. Vermont also had a significantly higher incidence of about 48.6 per 1,000 live births.
Breastfeeding as the primary modality of infant feeding is promoted both by the World Health Organization and the American Academy of Pediatrics. Infants should be exclusively breastfed for the first 6 months of life, with offering complementary food for the 1 year or longer. This is not only because the milk composition changes to fit the baby's changing nutritional needs, but also provides passive immunity that contributes to lower infection rates. Lower rates of inflammatory diseases over their lifetime, such as ulcerative colitis, Crohn's disease, eczema, and asthma, lower rates of obesity, lower risk of type 2 diabetes for both mother and baby, and less risk of breast and ovarian cancers for the mother, and lower risk of hypertension for the mother as well. Due to the close physical contact from mom and baby experienced through the act of breastfeeding, it also promotes a bonding between the two. Contraindications to breastfeeding would include having a disease that can be transmitted through the milk, like HIV, medications that may pass through the breast milk and be harmful to the baby, and illicit substance abuse, such as opioids and methamphetamines, to name a few. Since we are in the midst of an opioid epidemic, more infants being born to women that are addicted to opioids. Women who have used opioids and become pregnant cannot withdraw safely while pregnant, as it puts the fetus at an increased risk of demise. The mother may also not be able to safely withdraw from opioids, hence why these women began opioid maintenance programs such as methadone. This brings us to our PICO question. In neonates born to opioid-addicted mothers, does breastfeeding decrease the severity of NAS symptoms compared to formula feeding?
So to answer this question, we went on a literature search, as I'm sure all of you did, and we did our search in different databases such as CINAHL, EBSCOhost, PsycInfo, to name a few, and we searched for systematic reviews and national guidelines through several databases, including the Joanna Briggs Institute. Search terms that we used included neonatal abstinence syndrome, breastfeeding, formula feeding, maternal addiction, and opioid maintenance therapy. Our initial return was about 34 articles that we pulled after looking at the abstract content and the key and indexing terms for these articles. And after reading the articles more thoroughly, we narrowed it down to 12 for the final review.
The majority of the articles were retrospective cohort studies that looked at the charts of opioid-addicted mothers and their infants, assessed them based on the variety of NAS symptoms and feeding modality. Evaluation of NAS symptom severity included time to onset of withdrawal symptoms, average and maximum Finnegan scores, need for medication management, time to resolution of symptoms, and length of hospital stay. All of these studies showed a positive association with decreased severity NAS symptoms for infants who are breastfed. 2 different studies looked at the delivery of breast milk as either direct breastfeed or express breast milk, and both showed breastfeeding is still best compared to formula feeding. The results of the efficacy based on delivery were conflicting.
There was a study conducted in Scotland and released earlier this year that looked at the efficacy of a pilot program to promote breastfeeding among opioid-addicted mothers. And what they did for this study was they had a sample of 14 mother-infant pairs, so 28 individuals total, and they separated them into intervention and control groups. So it was a randomized control trial. The control group received the standard breastfeeding support that is offered to all mothers postnatally on this particular labor and delivery unit, but the intervention group received 1 hour every day of hospitalization. This hour included specialized assistance from a trained professional in how to promote breastfeeding among opioid-addicted mothers and infants with NAS, and they provided this assistance in a modified environment that blocked out stimuli to reduce agitation and distraction in the infant to help them better focus on the act of breastfeeding as these infants experience increased difficulty coordinating the musculoskeletal movements necessary to breastfeed. And they did find that this pilot program was successful not only in establishing breastfeeding for these mother-infant pairs, but also for the continuation of breastfeeding upon, leaving the hospital. So it was a very successful program. So based on the literature that we reviewed, we recommend that infants who are born to opioid-addicted mothers should be breastfed in order to mitigate symptoms of NAS. We also recommend that opioid-addicted mothers should be offered additional breastfeeding support in a modified, low-stimuli environment to promote the success of breastfeeding.
There is a lack of experimental studies on this topic. The major barrier being that a woman's choice to breastfeed is an extremely personal decision, and one cannot dictate how a mother should feed her infant.
Other barriers include a lack of specially educated and trained professionals to lead these efforts and to assist this population, the resources that are needed to train these professionals to assist this population and meet their highly unique and specific needs, and also the stigma related to this population. There's still a lot of reticence in this community or hesitance to allocate resources to train this population when it's largely believed that these issues were avoidable because of a behavioral issue.
There is enough evidence to support 4 women on opioid maintenance therapy in absence of other contraindictions, and this is actually recommended by the American Academy of Pediatrics. There's definitely enough information there to support for curriculum and for training for both nurses and healthcare professionals that are involved in obstetrician and pediatric care.
Yeah, and postpartum care. And there's also enough research and evidence to support the development of an official expert-recommended protocol to promote and sustain breastfeeding in this population. Here are the resources that we used for our study. And here it is in poster format. If you guys have any questions or comments or thoughts on this presentation, please let us know. We'd love to hear what you guys think. And thank you so much for watching.